We will now go on to the next topic, glotto-subglottic stenosis. Dr. KAALAN Johnson will deliver the talk on management principles of complex glotto-subglottic stenosis.
And I have an image of you guys, so that works great. All right, well, thank you so much again for having me virtually. I look forward to the next time, hopefully doing this in person and getting an opportunity to talk through these incredible topics with this group. And so we're going to finish with management principles of complex glotto-subglottic stenosis. And I hope that we can discuss the principles, and we'll use a small number of cases to teach those principles and discuss those principles, and get through some of the detail of the concepts with a detailed description of some complex cases, ending with some future directions and thoughts for upcoming research and study as well. So I'm in Seattle currently, and it is quite late, so I apologize if I miss anything, but I'm going to start with a case of a patient just looking at how we do endoscopies and in complex multi-level airway obstruction. So on the left, we have a flexible endoscopy that's kind of working. Hold on one second. And on the right is a rigid endoscopy on the same patient the same day. So one of the first important principles in complex airway management is that it takes a team. And so we work with our pulmonologists, our GI doctors, ENT, speech, nutrition, surgeons, and you have sleep apnea, so multi-level airway obstruction, tongue-based on the left, on the flexible bronchoscopy, and you can get down to the supraglottis and see that there is sleep-induced laryngomalacia for this patient. So while the flexible bronchoscopist is spraying the vocal folds with lidocaine, we'll look at the rigid endoscopy on the same day with the same patient. And you see on that same day, when you lift the epiglottis up, there's no longer this dynamic supraglottic collapse that you see on the left side, but you see in the glottis, there's a complex multi-level airway obstruction with a subglottic stenosis that has been deformed by the intubation that was required after the flexible bronchoscopy, and then an A-frame deformity as well within the subglottis with very little dynamics that you see on the right side because they're in a deeper plane of anesthesia at the time when a rigid endoscopy is performed. The distal trachea is normal. But on this patient, which we'll come back to later when we talk about the surgical management, because this subglottis did require a cricotracheal resection, when you go through the supraglottis and you see all this dynamic obstruction at that level in the supraglottic airway, there's also dynamic glottic level obstruction. And then when you get down into the subglottis, you see the complex subglottic stenosis, and the tracheal A-frame deformity is incredibly dynamic. See the posterior trachealis movement? So this illustrates why interdisciplinary management of these complex airways is really important. And that's my first introductory statement to this topic, is that playing in the sandbox with multiple other people gives you better outcomes. So involve your team. That's the first point. And that's a patient we're going to come back to. But I'm going to start after that introduction just with a discussion of some of the basic things underlying what we have to treat with embryology. And I am going to also go through some of the basic classification and some other management strategies very briefly, because many of these things have been covered in other talks this weekend. So if I feel like I'm rushing through things, it's just because I know you've heard some of this content already this weekend. But with embryology, it has also been already mentioned that week 10 is kind of that critical recanalization of the laryngeal lumen after it was obliterated previously. And a failure to do that results in laryngeal atresia, stenosis, or webs. The subglottis is the narrowest area of the pediatric airway. And we've heard about Poisson's law, where resistance is directly proportional to length and inversely proportional to radius to the fourth power. So very small changes in radius result in big changes in resistance, and that's why this is the most common and most important area of airway obstruction that we see in babies, especially for acquired subglottic stenosis, which is 95% of the problem that we see. So we've heard about intubation injury from Kishore Sandhu, but some other pictures of these tongues of Benjamin, the granulation tissue in the ulcerative trough that evolves into chronic injury with these tongues of granulation tissue turning into fibrous nodules, the ulcerative troughs turning into healed furrows, and cricoarytenoid joint ankylosis frequently occurring as well as interarytenoid fibrosis. So this results in a couple things. If it doesn't stenose, it can be vocally disabling furrows that I see in my voice clinic. And if it does stenose, you get Bogdasarian class 1, 2, 3, or 4 posterior glottic stenosis that is very challenging to manage. Here's a picture of a cadaveric specimen with interarytenoid fibrosis. So all of this results in narrowing, and that results in airway obstruction. So how do we describe that narrowing? The Cotton-Meyer grading scale is certainly the most commonly used, from 0 to 50, 51 to 70, 71 to 99. In grade 4 is no detectable lumen. But also, I'm sure Kishore would want us to mention, there's the Monnier scale, which is based off Cotton-Meyer, but also adds comorbidities and glottic and subglottic involvement. And these things can better track with outcomes for long-term decannulation and health in children. So we have spent a lot of time already on endoscopic management, which is generally grades 1 and 2, sometimes grade 3. And these thin webs, as Dr. Rudder had a picture of this balloon that he helped design, are fantastic to respond to a quick balloon dilation. So this has been mentioned as well, but make sure you don't forget when you're sizing this, it's based on the age-appropriate endotracheal tube outer diameter, and you add 1 millimeter for luck at the larynx and 2 millimeters at the trachea. So luck at the larynx and T2 for trachea is your alliteration to remember on how to size your tracheal balloons, because picking the right size is the most important thing. If they have trisomy 21, subtract a millimeter from those sizes. And Kenalog injections can be critically important for endoscopic management, in my opinion. Inject first and then do your chevron incisions and balloon dilation. This is another of my mentors. After my time in Cincinnati, I worked with Andy Inglis before he retired. He was the last CO2 laser samurai. He did so much work with the laser. But don't forget that as a great option, both for incisions and also for debulking laser. And I did want to just mention endoscopic work, because when you're talking about complex glottic and subglottic stenosis, we tend to think about open procedures, but don't forget that endoscopic procedures, as we were discussing earlier this week, can sometimes be critical management strategies, or even if they're not definitive management, they can be important neoadjuvant treatments for some of these patients. So this is one of my patients who was referred to me to consider a cricotracheal resection. And I said, okay, sounds reasonable, but let's first at least try to see if we can establish a lumen while they're waiting to be medically and socially ready for the LTR, which took them 3 or 4 years to occur. So during that period of time, we did an extensive laser excision. This is after dilation and lasering. Came back 2 months later, it was still a grade 4, but it was noticeably thinner. And so when we lasered things out that time and injected steroids, it took us over a year to come back, but they were now down to a grade 3 subglottic stenosis. So you can see just with those interventions, now she's able to talk. So she's developing speech, and she's much safer while she's waiting for her LTR. So again, we did steroid injections and balloon dilations. She leaked with a 2.5 endotracheal tube at that time. And the next time we were able to get her into the operating room this summer, she had actually leaked freely around a 4.0 tube, and a 4.5 passed easily. Meanwhile, this whole time she's developing speech, and at this point she's now tolerating some capping. So I decided to again do a Kenalog injection, did chevron incisions, and a 9 millimeter balloon dilation, and this opened up pretty nicely. So she's a patient with a grade 4 who might be able to avoid an airway reconstruction with 3 endoscopic interventions. So don't forget that that is an option and something I would strongly consider if their airway looks amenable to it and if the family has the time. But most of the time when you have these thick stenoses, you can attempt lasering and interventions, but open procedures are going to be more commonly recommended. And we've already talked about single versus double stage. Some of these slides, I'll give credit to some of my mentors in Cincinnati and also Dr. Andy Inglis, my mentor in Seattle. But if you're doing a single stage or a double stage, which most of our procedures are, you get to kind of sit back and do a couple days in the ICU, and then they go home and you take the stent out. It's all nice and relaxed. Where the single stage, which I talked about yesterday, this is a picture of Dr. Inglis bungee jumping. So it's a much less relaxing experience because you put all your eggs in that one basket for your extubation attempt to occur about a week after surgery, and you hope that everything sits the way you want it to sit and heals well during that extubation. For augmentative procedures, I tend to use costal cartilage graft. It was fascinating to hear of your experience using auricular cartilage as well, which is, it'll be interesting to see what your long-term perspective is on that, but great results are fun to hear. And when we're doing the boat-shaped grafts for the costal cartilage, Dr. Andy Inglis loved to put grafts in without the side flange, and I just wanted to mention that because I tend to leave a side flange as well. All of these are good options, but the only thing we don't generally recommend is to not have any flanges, as the graft can fall into the airway. For posterior grafts, a similar kind of a keel shape to notch that in, and we've spent some time talking about that already. So the one other case that I'll throw in for open management, because I had mentioned this earlier, these pediatric endotracheal tube stylets can be a great tool if you want to actually try to feel and confirm if this actually is a grade 4 stenosis or if it's something less than that. There's 2 little openings in this patient who'd come to us after 25-week prematurity and prolonged intubation with multiple failed endoscopic attempts at an outside hospital. And he really did have a true grade 4 subglottic stenosis at the time. And so I thought the airway looked relatively calm enough to attempt some laser procedures, but I was unsuccessful. It remained a grade 4. And as we continued our workup, they were diagnosed with eosinophilic esophagitis, which required treatment for more than 2 years before I was actually able to have that be biopsy negative and take this patient for an open laryngotracheal reconstruction with anterior and posterior costal cartilage graft placement. So this is an intraoperative picture of the posterior graft and the anterior graft. You can see a nice glottic aperture. I tend to use an endoscopic assisted anterior cricoid split to make sure that my incision goes right up to the undersurface of the vocal folds, because I think that's one of the most important considerations for long-term voice outcomes. This patient, due to their chronic inflammation, did require 1 balloon dilation postoperatively, but then leaked around a reasonably sized tube despite some persistent posterior subglottic stenosis. They were able to be decannulated. And one of the things that I think is really important, again, is this anterior commissure with the split and the graft extending right up to the undersurface of the cords. He actually has a really nice voice result so far that we're looking forward to maintaining. So open procedures, again, the importance of a team. So I'm leaning heavily on my GI colleagues to manage the eosinophilic esophagitis for that patient. But for a lot of these patients, if an augmented procedure has failed, or if you just feel like being more definitive with a resection procedure from the get-go is the best approach, often your grade 3 or grade 4 subglottic stenoses would be things that you'd consider a cricotracheal resection for. So the concept here is that instead of augmenting the trachea, we're removing the diseased segments and connecting these healthy segments. Again, generally for more severe stenoses, concentric scarring for salvage procedures. You can do either one for congenital anomalies, but is sometimes favored for that. And relative contraindications are if it involves the vocal folds at the level of the glottis. But for a cricotracheal resection, you can consider an extended partial cricotracheal resection and do a posterior graft at the same time as your CTR procedure. So I looked at a couple studies on outcomes for this, trying to decide which one was better, and compared Monier's reviews of his large LTR series from 2014 and 2015 with CTR to Cotton's series, which were a little earlier, but of LTR and CTR. And I found it fascinating that, they're both doing large volumes, but Monier's group was doing about an equal number of CTRs and LTRs each year, where Cotton's group was doing almost twice as many LTRs as CTRs. But despite that difference in experience, their overall decannulation rates for LTRs were remarkably similar, and their operation-specific decannulation rates, again, were similar. And then for CTR, slightly higher overall decannulation rates, but again, similar between the two groups, and the same for operation-specific decannulation rates. So if you do a reasonable volume of these procedures, I think the bottom line is you can get good outcomes, whether you tend to start with augmentative procedures or resection procedures first. So I'm going to circle back to the first case I started with. I mentioned that she was a premature baby child who was 18 when we met her, coming from an outside institution, and she had this CTR, or this anterior and posterior costal cartilage graft at 3 years old and was decannulated, but then had developed these late airway complications with a 3-year history of progressive dyspnea on exertion, had moderate to severe sleep apnea requiring CPAP, and significant dysphonia, and was hoping to go off to college, but really was not in good health to be doing that. So one of the important things that I recommend for patients like this, if dysphonia is a part of their symptom profile, and even sometimes if it's not, depending on what you're planning to do with your procedure, is a voice clinic evaluation preoperatively, because she had this supraglottic obstruction and was actually able to produce a supraarytenoid tissue to petiole supraglottic speech, which was a deep froggy voice, and that was easier for her to get loud. But she also had false vocal fold phonation, which was a higher pitched voice, which was more clear, and she preferred the sound of that voice but wasn't able to get as loud with that voice. So she tended to use her froggy supraglottic voice with supraarytenoid tissue to petiole frequently because it got more loud. But we had to talk to her about this, because if you want to improve your sleep apnea for the sleep-induced laryngomalacia that we saw in her sleep endoscopy, you would need to do a supraglottoplasty. So we counseled her preoperatively on that before her triple endoscopy, and actually performed a supraglottoplasty on that day, with counseling in voice clinic to say that froggy voice is going to go away. Are you okay with that? And you could talk about that ahead of time. So that was the initial preoperative evaluation. And then we took her for a cricotracheal resection and performed an anterior midline split first, because if you decide to change your mind and go with an augmentative procedure, you can still, after a midline split, do an anterior and a posterior graft. But if you do a transverse split first on your CTR, you're committing to a resection procedure. So start with a midline split, and then you start resecting the diseased segments. You separate the trachea from the esophagus, watch for your recurrent laryngeal nerves, stay right on the perichondrium as you go back into the fibrous plane between the two. If you need to, you can drill down the cricoid at that point. Then you place your lateral retention sutures, which go down around 1 or 2 tracheal ring and back under a ring, coming out submucosally and going deep within the cricoid and up into the thyroid cartilage. These are what are going to retract your CTR and pull that distal trachea up into the cricoid. So once those are seated, you can pull that up partially, so the posterior trachealis flap approximates the mucosa posteriorly. And then I tend to use a running suture and go across the back first and fill that first half of the posterior anastomosis. Then I'll pull my lateral retention sutures tight, and finish off the anterior half of the running anastomosis with a single PDS suture, tie down those lateral retention sutures, and then I'll do an anterior retention suture that I'll go loop up around the hyoid. If I do that, I can usually get away with a C collar and don't have to do any chin to chest sutures, but that is quite effective to treat that type of a subglottic stenosis. So she came back to voice clinic post-operatively, and you see that supraarytenoid tissue reduction that we did with the supraglottoplasty resulted in her phonatory source being only at the false vocal folds now. So she's still a supraglottic phonator, that froggy voice is gone, but that higher pitched clear voice she liked and was able to work on with voice therapy to try to improve that. And 1 year later in voice clinic, that higher pitched voice was even stronger, and she was very satisfied with her voice result. So the airway result also worked well. Unfortunately, this is a week post-op. I don't have her 1 year post-op, but you can see that her anastomosis held. She had no airway symptoms, and her sleep apnea also resolved. So again, this is a pre-op and post-op for the subglottis. Now her voice changed due to her supraglottic phonation being altered, which is a component of complex airway reconstruction that you have to consider. But every patient who undergoes a cricotracheal resection can expect some changes in voice, because we know that this does alter your fundamental frequency. Your pre to post operative mean FO decreases. So especially singers, you want to counsel them that the vocal folds, which were kind of longer preoperatively, end up just a little bit shorter. And when you're phonating with a shorter glottis, you will have a lower fundamental frequency. So that's something to be aware of. So CTR is a great option either after or before LTR. You can do a posterior graft with it if you need to, but it's a procedure that surgical technique really, really matters. You have to perform each step very carefully and evaluate and counsel patients for the voice outcomes related to CTR management. So that patient had some of the late airway complications and was a good CTR example. I'm going to talk through one more patient. A lot of fun, but he when he got sick was terrifying. His mom was an ICU nurse by training, and she couldn't manage him when he got sick because he'd had a single stage LTR with anterior thyroid alar graft and a revision double stage with anterior and posterior costal cartilage grafts. But when he got into his teenage years, he developed basically all three of the most common late airway complications. So I'm going to teach you about those three if you're not well aware in this one patient. And so his symptoms, as I mentioned, he was terrifying during illnesses. He developed severe obstructive sleep apnea, and he had a complex dysphonia with two forms of supraglottic phonation as well as inhalational speech. He still loved to sing Sesame Street songs with that voice. But the three complications he had were an epiglottic petiole prolapse. He had right arytenoid prolapse. His glottis, where he'd had two previous surgeries, was great. That was the only thing that worked really well from his prior surgeries. But then he had a tracheal A-frame deformity, which was dynamic. And all these things resulted in baseline stridor for him and exercise limitations. But again, when he got sick, he was truly terrifying. So this is the picture of his endoscopy, and this is just another picture from a textbook about the dynamic nature of the tracheal A-frame deformity, which you saw on our first CTR patient as well. This can be very dynamic at the trach site. So his airway, interestingly, if you look from May of 2018, there was more space in the glottis. In March of 2020, this space here had disappeared. And so this right arytenoid was tightly pushing up against the petiole, which was prolapsing posteriorly. And that was probably his most significant level of obstruction, especially during sleep. So that progression is what correlated with his symptom progression over those 4 years. And so we decided to address both of those levels of obstruction in a staged manner. So the petiole repositioning was the first step. This is the epiglottic petiole, which is normally up here with lots of space, but can prolapse back and cause this obstruction, which if it's here is asymptomatic, but for him it was actually all the way back touching his arytenoid and was quite symptomatic. And this is a framework issue. So you can go in, do a complete laryngofissure, and actually place sutures through this epiglottic petiole to tie that up to your thyroid cartilage as you close your laryngofissure. We tend to do that with stenting to hold that in place afterwards. And for this patient, you can see this is the epiglottic petiole, which is tightly touching the arytenoid. And then afterwards, there's this V-shaped tent where it's pulled straight forward as you close the laryngofissure. And then again, stenting for about a month afterwards. So that addressed the anterior petiole. We also did a laser reduction of his right arytenoid prolapse. And so you can see there's no space between petiole and arytenoid pre-op, and post-op there's a fair amount of space there, even under anesthesia. And awake, that space was even better. So we had treated the supraglottic obstruction with that, but still he had his tracheal A-frame deformity, which we did a tracheal resection for that, and the anastomosis ends right here. So that worked really well as well and got him decannulated and was no longer terrifying, still with a compromised but reasonable voice. So that was our late airway complications. In conclusion, I do think airway stenosis is something that does really require interdisciplinary management. And even if it's a complex or multi-level or very severe stenosis, you can always consider whether an endoscopic management approach may be something that, even if it's not definitive, could help you with neoadjuvant management of that airway. Open airway surgery can have some great outcomes, whether you're doing augmentation or resection. And then be aware and counsel your patients that late airway complications can show up after reconstructions, and that can include the big three: petiole prolapse, arytenoid prolapse, tracheal A-frame deformities, and monitoring, at least symptomatically, for those until the patient reaches skeletal maturity or complete growth of their airway is critical. Careful planning is paramount, and that actually leads me to my future directions slide, which I just wanted to mention because I'm not going to be able to be there this afternoon, unfortunately, that for patients that have slide tracheoplasty procedures being performed at our institution, we are moving into advanced surgical planning techniques with that, where we not only discuss them at conference, but we actually do surgical rehearsals using 3D printed models of their airways. And you can see the model on the left and the bronch on the right preoperatively, and then postoperatively, that same model has a similar figure 8 deformity as to the post-op result from that patient, which has been great for rehearsal, and it helps us also with surgical planning and some research on surgical techniques, not only to determine volume, but we're now using that for computational fluid dynamics evaluations, which is great. And I was really looking forward to showing you guys all that stuff, even the stuff we're doing with tracheostomies to print 3D printed personalized tracheostomies for patients with our simulators, but that'll have to wait for next time. So thank you all so much again for the opportunity to be here virtually with you for so much of this weekend. And I really look forward to doing this stuff in person at some point.
Thank you, Dr. Johnson.